It's 21:30.
Hello, everyone, and a warm welcome to today's edition of Pathcast. Today is Tuesday, April 5, 2022. I am Rifat Mannan in California, and I'm remotely joined by my good friend Emilio Madrigal, who is in Boston now. So today we are going to have a session in dermatopathology, and we are delighted to welcome two distinguished speakers. One is a dermatologist and one is a dermatopathologist. They both are joining from India in New Delhi. And the title of today's talk will be Infections of the Skin, and it will be a multi-part talk. So today will be part one. Let me introduce Dr. Neetu Bhari. So she is currently working as associate professor in the Department of Dermatology and Venereology at the All India Institute of Medical Sciences in New Delhi. And she is also an assistant editor of Indian Journal of Dermatology, Venereology, and Leprology, and also the Indian Journal of Pediatric Dermatology. She has been a member of WHO expert panel preparing index guidelines for extrapulmonary tuberculosis. Dr. Bhari has more than 120 publications in indexed journals and more than 40 chapters to her credit. And her area of interest includes pediatric dermatology as well as dermatopathology. Welcome to our session, Dr. Bhari. And
Thank you.
let me also introduce Dr. Manoj Singh. So Dr. Singh is a former professor and chair in the Department of Pathology at All India Institute of Medical Sciences in New Delhi. And in his long and illustrious career of over 40 years, he established the first diagnostic dermpath lab in India. And Dr. Singh has authored and co-authored many books and articles on dermatopathology. And in fact, he was instrumental in founding the Dermatopathology Society of India, and for which he was for many years the secretary and later the president as well. And he has also been the vice president and the president of the Indian Association of Pathologists and Microbiologists. At present, Dr. Singh is focusing on virtual and distance teaching, and he has also established an independent diagnostic dermpath unit named Dermpath Diagnostics. So with that, I would pass on the microphone to Dr. Bhari and Dr. Singh, and thank you both for joining us. And over to you now.
Hello. Good morning, good afternoon, good evening, depending on which country you are in at the present. My name is Manoj Singh, and my partner in this venture is Dr. Neetu Bhari. She is a dermatologist, and we will be approximately splitting our content. She will be talking about the clinical aspects, and I will be talking about the pathological aspects. So we start.
Thank you, sir. Thank you, Dr. Rifat, for the kind introduction. Thank you, Dr. Manoj, sir, for this opportunity. In leprosy, which is our first infectious talk for the today, first and foremost, we should know that it has a spectrum of disease presentation. And this spectrum actually depends on the immunological state of the patient. So that means after infection with Mycobacterium leprae, the disease may limit itself to the tuberculoid form of leprosy, which is the paucibacillary form of leprosy. If patient has a good immunological status, or the reverse is also true, that if patient has a poor immunological state, the patient may develop a florid manifestation of disease, which is Lepromatous leprosy. So thus the spectrum will depend on what is the immunological state of the patient. Next slide, please. Globally, this spectrum has been classified using Ridley-Joplin classification of leprosy, which is based on 4 main criteria: the clinical appearance of the lesion, bacillary load of the lesion, histopath appearance, and lepromin test, which is a test to measure cell-mediated immunological status of the patient. Based on these 4 criteria, we have 5 main type of leprosy presentation. 2 polar type are tuberculoid and lepromatous leprosy, as we discussed. We have 1 borderline type, and then in between we have borderline tuberculoid and borderline lepromatous. In addition to these 5 distinguished types, we also have indeterminate form of leprosy and reactions in leprosy, which we will talk about in the coming slides. So as per Ridley-Joplin classification, if we go from tuberculoid to lepromatous pole of leprosy, we will see that number of skin lesion increases. As we discussed, cell-mediated immunity reduces, and that's why number of bacilli in the lesion increases. So this is the main basis of the classification. Paucibacillary, where tuberculoid pole is included, and multibacillary, where lepromatous pole is included. To detect the bacilli load in a particular patient, we do the slit skin smear, a procedure, OPD procedure, which is called slit skin smear, where we use this surgical blade, and most commonly the site which is done is ear pinna, but if a patient has infiltrated skin lesion, that is also included. Prepare a smear on a slide, use Jaden staining, and see the bacillary load of the patient. So in the microscope, we see it in oil immersion field and count the number of bacilli per oil immersion field. If we see lot of bacilli, we will go up to 25 field, otherwise we will see 100 oil immersion fields. So based on this, we will measure the bacillary index of that particular patient. As we can imagine that in tuberculoid pole, the bacillary index will be in the range of 0, 1 or 2, while in lepromatous pole, the bacillary index will be high. So thus, based on the Ridley-Joplin classification, we will classify a patient based on the clinical appearance, bacillary load, and then we also do histopathology for the confirmation and documentation. Lepromin test is now obsolete. It is mostly theoretical. A word about reaction in leprosy, which are actually sudden immune-mediated change in the clinical and histological course of the disease. In the coming slide, we will see that there are 2 types of reaction, type 1 reaction and type 2 reaction. Type 1 reaction is because of a sudden change in the CMI response, which is cell-mediated immune response to M. lepri, and it is seen in the tuberculoid pole of the leprosy. While type 2 is an immune complex disease, and it is seen in the lepromatous pole of the leprosy, where the bacillary load is high. So let's go one by one describing the spectrum of leprosy. First spectrum is tuberculoid leprosy, where both tuberculoid and borderline tuberculoid leprosy are included. So as we discussed, the number of lesions are fewer in this type of leprosy. So we will see number ranging from 2 to 5. These lesions are well defined. They may be erythematous, they may be hypopigmented or hyperpigmented. There is significant amount of sensory loss in this lesion if we check it with pinprick or cotton. And then we will see that there are some satellite lesions, which are smaller lesion in the vicinity of the larger lesion. Similarly, nerve involvement is also limited in tuberculoid pole of leprosy. So if you palpate around the lesion, you may feel a feeder nerve or a single 1 or 2 nerve in the course of the lesion. Like we can see ulnar nerve here, greater auricular nerve in the next picture may also be involved. This is a characteristic lesion which we see in borderline, that is BB leprosy, which is known as inverted saucer appearance. And this is because of the sloping inward edges of the lesions. So again, you can note that there are small satellite lesions in the vicinity of a larger plaque.
In the biopsy of tuberculoid leprosy, we see 2 or 3 major changes, groups of changes. One is, of course, the dense chronic inflammation which is present in the upper dermis and may also be present in other parts of the dermis. Please note this particular appearance. This is a appendage or a nerve or something which is forming a string of granulomas and inflammation and surrounded all around by this blanket of lymphocytes. This appearance, just come to that, the cells of tuberculoid leprosy, because there is a fairly high amount of immunity, there are epithelial cells, there are granulomata. So we have these nice looking granulomas, lot of lymphocytes. And a huge amount of work has been done actually on the immune response in leprosy, which we will not spend very much time on this time, perhaps at a later talk. And here you can make out again that same appearance, dense inflammation, tracking the appendages, granulomas. Granulomas may be well-defined or ill-defined. And this appearance that I have been mentioning is this characteristic appearance of the inflammation following the appendages. This is known as a coat sleeve appearance. And this, even on the scanner, is suggestive that this lesion without any history could be leprosy. You make out in all of these lesions, these are tuberculoid or borderline tuberculoid. You see that there are granulomas and rimmed by a large number of lymphocytes. Granulomas here, few lymphocytes in the granuloma, but around the periphery, you have a fair amount of lymphocytes. And of course, the other concomitant, Langerhans giant cells in granulomas. And you can perhaps make out here these fibers, right? Now, these are smooth muscle fibers. And this is an erector pylorium muscle, which has been destroyed by the inflammation. This, perhaps you all can recognize, is a nerve twig, which is inflamed and also surrounded by inflammation. And leprosy, particularly, is a neurotropic infection. It involves preferentially the nerve sheath material and causes inflammation and destruction of the nerves. And in earlier times, of course, we had very complicated nerve stains. These days, do a S100 in immunohistochemistry, you are able to make out that there are small nerve twig-like structures which may be destroyed. And in fact, one of our gurus, Dr. Ashok Mukherjee, used to tell us that if you are thinking of leprosy, look at it very carefully. And if you don't see nerve twigs, then you suspect leprosy. Now, that logic was a little difficult to understand, but the issue was that the nerve twigs get destroyed, and that damage and later destruction and vanishing of the nerve twigs, in fact, results in the paresthesia or anesthesia of leprosy, which is one of the major causes of the clinical manifestation of, atrophic fingers and toes and so on and so forth. So we come to the other pole, which is Lepromatous, which is BL or LL. Neetu?
So as we discussed, Lepromatous pool is seen in patients who have poor immunity against the bacilli. So the manifestation is much more florid. We will see multiple or numerous number of lesions. The lesional morphology may extend from multiple well-defined hypopigmented macule, but the anesthesia over the macule will be less prominent here compared to tuberculoid pole, and the manifestation will vary from well-defined hypopigmented macule, or we may have multiple innumerable skin color infiltrating papulonodular lesion. The infiltration will involve all over the body, even the background skin. That will result in this thick dye skin in the background. Forehead lines will be infiltrated, so we may see a mask-like appearance. Eyebrows will be infiltrated, so there will be loss of lateral eyebrows, known as madarosis, and even earlobe infiltration is seen in these patients. The nerve involvement is also much more florid here. So we see thickening of bilateral symmetrical multiple nerve thickenings are seen. And similarly, hypoesthesia. In tuberculoid pole, we saw that the hypoesthesia is limited to lesion. Here we will see bilateral gloves and stocking hypoesthesia in both upper and lower limb. And because of this florid involvement of nerves, there will be motor impairment as well. There will be presence of trophic ulcer, claw hands, and wrist drop or foot drop as a secondary manifestations.
Histologically, again, in Lepromatous leprosy, there is a dense inflammation in the upper and mid dermis. But the nature of the inflammation is slightly different. If you remember back in tuberculoid, the inflammation started right from the subepidermal zone. In places, in fact, the Grenz zone, which is this area between the epidermis and the rest of the dermis, this also might have been compromised. In Lepromatous leprosy, it seems to be preserved. The nature of these cells is, of course, different. As you cannot make out here, you can just make out that these are it's a very dense infiltrate. We see here. Now, these are a large sheet of cells. These are not epithelioid cells, the way you saw in tuberculoid leprosy. You see here, again, not epithelioid cells. These are histiocytes. Many of them have a foamy cytoplasm. Many of them have a pink cytoplasm. And here, if you think back to tuberculoid leprosy, this is a nerve bundle. This is a nerve bundle. And you can make out that because the CMI is less than in tuberculoid, as I said, Mycobacterium leprae is neurotropic. So these nerve fibers do contain mycobacteria, large numbers of mycobacteria in some cases. But the consequent damage and destruction of the nerve is less than in tuberculoid. So clinically, it is slightly different, that the amount of anesthesia, paresthesia is less. And as you see in slide after slide, you have, this is a perivascular infiltrate, vessel here, and a dense gathering of these foamy histiocytes and lymphocytes. Foamy histiocytes and mixed with lymphocytes. A slightly lower power, the sebaceous apparatus, and rimmed by this kind of a infiltrate. And a high power of this, just to show you these foamy cells and a Ziehl-Neelsen stain. For acid-fast bacilli, you can make out that there are large number of acid-fast bacilli. This is, of course, the high power. You could, perhaps see them a little better in an oil immersion objective. But you can make out here that these are large number of acid-fast bacilli. And again, a similar picture. And kindly note this, a very large histiocyte containing this dense globule of red. This is actually a huge number of bacilli. And these together are known as globi. So this is a globus cell containing a globus of acid-fast bacilli. And of course, all around in the other cells, you can also make out that there are varying numbers of acid-fast bacilli. Again, the feature I had attempted to point out, you see this brown stuff. Any comments on this? This is melanin. This is the basal layer of the epidermis. This is where the inflammation starts. And the Grenz zone is beautifully preserved, even in this state. As you saw in the HND, even here, the Grenz zone is preserved. Higher power or a larger area showing you many loci and individual acid-fast bacilli, groups of acid-fast bacilli. And this was the Zeal-Nielsen stain, which has been traditionally done for a long time. This is the current variant, auramine-rhodamine, wherein using the UV microscope, you can make out the bacilli which stain a golden yellow. And some people feel that the pickup here is better than the pickup here, because you see here the contrast is between red and blue. And unless and until your background blue staining is light enough, if it is dark, then this becomes difficult to pick up, especially when you don't have globi and you have single. And here, because it's a black background and this yellow bacilli are shining through, the pickup is easier.
So as we discussed, there are two types of reactions in leprosy. Type 1 reaction is seen in tuberculoid pole of patient in TT or BT type of, mostly BT and BB type of leprosy. There, what happens is a pre-existing lesion of leprosy, whether it was a hypopigmented or a hyperpigmented plaque, suddenly it becomes inflamed, that is, it becomes red, painful, tender, and then there may be associated new onset neuritic complaint as well. There may be pain in the nerve, there may be new onset sensory or motor impairment. It is because of change in CMI, sudden change in the CMI of the patient, and this is called type 1 or reversal reaction. While the type 2 reaction, the cutaneous manifestation of which is known as erythema nodosum leprosum, is seen in the Lepromatous pole of leprosy, where the bacillary load is high. A patient may de novo present as ENL, or it may be a known patient of Lepromatous leprosy or borderline leprosy who has been started on multibacillary therapy and then has developed type 2 lepra reaction. In type 2 reaction, patient present with a crop of evanescent tender erythematous nodular lesion. Associated there may be fever, neuritis, or many other systemic complaints, including hepatitis. There may be renal involvement, suprarenal, endocrine, hematological. So there may be a systemic involvement as well, in addition to these tender nodular lesions, which are mostly seen on the face and extremities. These lesions, with treatment, they subside in few days, but then there is a recurrence. Sometimes we see that these nodular lesions, they develop vesiculation and ulceration. And the morphological term used for these lesions is that necrotic ENL, because of their appearance. So here we can see a patient who has developed ulceration of her ENL lesion. So the term necrotic ENL will be used. In these patients, we continue their MBMDT therapy, their multibacillary treatment for leprosy, and in addition, a treatment for reaction is also given. So as we can see, ulcerated nodular lesion, and this is a patient where slit skin smear has been performed, one from his ear pinna and second from his nodular lesion of ENL. As we will see that in ENL, fragmented bacilli are seen because of the immunological reaction.
So, as Neetu has mentioned, leprosy essentially, it's not a static disease. If you follow up a patient, you will almost always see that the patient moves from one category to the other. In other words, the immunity as it changes, the patient moves from, say, LL to BL. And many times, this immunity change is actually helped by the chemotherapy given. So, if an LL patient is given chemotherapy, there may be associated change in immunity and the patient may come to you next time as a BL. So it's for this reason that at least in institutional care of leprosy, patients keep a record, and we keep a record of the slit smear findings and as and where possible of serial biopsies. So in erythema nodosum leprosum, what you see is 2 or 3 distinct changes in both types of reactions, of course, because it's a sudden acute inflammatory change. You will see edema. In ENL, you will see some amount of vasculitis, and this change may spill into the underlying fat, into the paniculus. And again, the nerves may become edematous. And in fact, part of the clinical profile of this may be, subtly exaggerated nerve response. So, as we can see here, this is actually a nerve. You can make out the surrounding nerve capsule, and inside, whatever cells they were have suddenly become edematous. This is muscle, hair follicle muscle, the erector pylorem, and this again is being destroyed, and it is edematous. And of course, bacilli are present. And one of the rather peculiar changes which one sees in erythema nodosum leprosum is that against expectation, sometimes you do not see bacilli, or you see very few bacilli. You have to search for bacilli. And this would naturally create a question in the mind that maybe this is not a Lepromatous leprosy which is traveling from here to there, that this actually is a tuberculoid leprosy. What happens in Lepromatous leprosy, which has suddenly undergone a reaction, is that the reaction at times kills all the bacilli. So you may have to look very hard to look for some small bacillary remnants. And not to say that bacilli had not been there, they were there, but they've been very suddenly destroyed. And here you have another change which may be associated with the reactional state. In tuberculoid leprosy, quite different from tuberculosis. In tuberculoid leprosy, usually you do not see necrosis, which is part of tuberculosis. But as part of a reaction, this necrotic focus may develop. In fact, one of the clinical photographs which Dr. Neetu had shown you, the one of the elbow and of the neck, when there was a nodule in a cord, that essentially means that anywhere thickened nerve, in that one small area has become necrotic, maybe full of pus, and that has become something in the nature of a nerve abscess. So these significant changes which you see in reactional state is increasing number of inflammatory cells, eosinophils, and again in tuberculoid leprosy, which is coming towards the borderline area, there may be an increase in the number of acid-fast bacilli.
So a distinct form of leprosy apart from the 5 one described in Ridley-Joplin classification is neuritic leprosy. So this has not been described in the classification, but we see it occasionally. And here one or multiple nerves may be involved, And then we will see sensory and motor impairment along that nerve. Like we can see wasting of the hand in this patient where the nerves are involved. And in this type of leprosy, the important thing is that nerve biopsies are done, particularly from sensory nerve, like we must have done biopsy from radial cutaneous nerve in this patient instead of biopsy from a skin lesion.
So, as we have seen earlier also, nerve, which is almost not recognizable as a nerve. This is the nerve surrounded by inflammation, and inflammation going all through inside. In a higher power, you can make out that the fibrillary nature of the nerve is there, so you can recognize this area as a nerve. But a lot of destruction going on all around it. The same thing here. Similar thing here. You can make out that this is a nerve surrounded by a dense inflammation, and the nerve itself is getting destroyed. And this is what I had mentioned, that necrosis may be seen. We have here giant cell, Langerhans giant cell, epithelioid cell granulomas, and necrosis. And in fact, this is one of the postulates for this necrosis inside a nerve, the nerve abscess, that when there is this extent of edema, which is part of the overall reactive process, the nerve capsule, the fibrous capsule, does not allow this inflammatory tissue to expand. And for that reason, this inflammatory tissue inside the nerve capsule, because of vascular compromise, degenerates and becomes necrotic. And an S100 stain, just to highlight the nerve destruction which you may see in the large and the small nerve fibers. The same kind of a picture there. And some of these are the counterparts. See this myxoid degeneration going on inside the nerve. And here, as I had mentioned a little earlier, you can make out that this whole thing is a nerve, but you can recognize actually very few intact fibers. The rest has already been destroyed. So maybe a month or two down the road, the whole thing would not be recognizable. You might not even see any S100 positive material, let alone recognize it in HNE.
Another unique type of leprosy not included in the classification is histoid leprosy. And this is a form of leprosy which has distinct clinical, microbiological, and histological appearance. Clinically, patient present with these well-defined, juicy nodular lesion, which may be skin color to erythematous, present mostly on the trunk and extremity, sometimes face may be involved. But the distinguishing feature of histioid leprosy from lepromatous leprosy, where we may also see similar papillonodular lesion, is that background infiltration is absent in histioid leprosy as compared to lepromatous leprosy. Next slide, please. So we see here the patient has presented with well-defined, juicy, erythematous to skin-colored papillonodular lesion without background infiltration of the skin as compared to lepromatous leprosy patient.
And the peculiar thing about the described morphology of histoid leprosy is that you do not have foam cells in it. These are actually fibroblast-like cells in the classic description. And these are sheets of fibroblasts-like cells, which at times may have some resemblance to a fibroxanthoma or something. Unfortunately, in many cases of histoid leprosy, perhaps even the majority, we do see foam cells here and there. So it's not such a difficult histological diagnosis. But what is striking, you can make out here that, those the foam cells of Lepromatous leprosy are not here. Actually, these are fibroblast-like cells, pink cytoplasm. However, that may be large number of acid-fast bacilli are present inside this pink cytoplasm. So even if it does not, evoke that foaminess, the amount of lepra bacilli is very high. And as I said, in many cases, I have not counted how many, but in many cases, you do see foam cell areas also. So recognizing it on HND is usually not a very difficult task. But of course, the AFB confirms it and the AFB looks very pretty. So, thank you. Rifat.
Thank you, Dr. Singh and Dr. Bhari. There is one question that I saw online, and the question was, they want to know which stain is preferred, whether you preferred Fight or Jill Nelson.
As you all know, the whole family of stains is, is the same family of stains. And the basis of the stain is the high amount of lipid and oil-like material in the wall and the cytoplasm of the acid-fast cells. And you will see this in lepra, mycobacterium leprae, mycobacterium tuberculosis, and many other mycobacteria. Now, the basic difference between these is very simple. The basis of the stain is that you immerse it in hot carbol-fuchsin or for a long time, or strong carbol-fuchsin. So the everything gets stained, right? And then you decolorize it. And it is described that TB bacilli are more resistant to decolorization compared with leprae. So if you have, say, you may use different materials for decolorizing. You may use acetone, you may use dilute acid, and TB is supposed to be more resistant. Now, essentially, this is the basis, and there are 3 or 4 or 5 stains which have been described based on this. One is Ziel-Nielsen, one is the Fight Faraco. They have the same basis. The actual concentration of the stains and all is different. The 2 important issues for staining mycobacteria, you may like to keep a note of. One is this differential between tuberculosis and leprosy, that Mycobacterium TB is more resistant to decolorization because of the constitution of the wall. So, especially in things like clinical pathology specimens, sputum or fluid or so on, this may at times be of relevance. The other is the stain which is currently very much in fashion, called the Wade Fight Faraco. And in this, see, what happens is you're talking about paraffin sections, right? Part of the paraffin section is that you cut the section fix it in on a hot plate, and then deparaffinise it. And it's only when it is deparaffinized from paraffin to alcohol to xylene to alcohol and then water, only then do you do the stain. So as part of the xylene and acetone process, some of the oil or fat in the wall of the mycobacteria also dissolves out. So that particular mycobacterium becomes less acid fast than it would have been otherwise. So some clever people have devised a different deparaffinization solution. They use in the xylene, they add different constituents like either peanut oil or paraffin oil or something. That is a gentler deparaffinizing agent. So the amount of reduction of the acid fastness of that particular bacillus will be less. So the pickup rate will be better. That is the basic idea behind doing this. Any other question?
No, thank you, Dr. Singh. Actually, you can go ahead with your next presentation and we can take more questions later at the end of it.
Okay.
Thanks.
Little bit about the philosophy of starting off with these guys, leprosy and tuberculosis. For us in India, leprosy and tuberculosis are very important problems, as they are in areas of Africa, South America, and so on. In many parts of North America, Canada, Europe, these were not. Tuberculosis was, of course, but they seem to have, with better living conditions, better treatment, they seem to have reduced significantly. But the counterpart is there, that if a pathologist or a dermatologist in these areas sees a leprosy case, they might or might not be able to diagnose it. The same thing for a dermatopathologist. So it's an important thing to be aware of these differences. Let's now go on to tuberculosis of the skin. Tuberculosis, of course, is a very, very common disease in India. And because it's a very, very common disease in India, mainly involving the lungs and other internal organs, tuberculosis of the skin also is fairly common for us. Neetu?
Sir, please share your screen, sir. Slides are not visible yet.
Huh?
Slides.
Please
Share the
share
screen.
the screen, sir. Slides are not visible yet.
Oh. Oh, I wonder what happened there.
Yes. Yeah.
Okay.
Yes. Thank you.
Yes, so as I mentioned, just a word about the epidemiology of tuberculosis, emphasizing the great burden of the disease, that according to WHO in 2017, 10 million people developed tuberculosis, and the highest number was from India. Also, the disease is important because it has a high mortality, particularly in the HIV infected patient. Cutaneous tuberculosis per se is caused, tuberculosis, as we know, is caused by Mycobacterium tuberculosis, and this organism, it has this characteristic morphology. That's why we recognize it with acid fast stain, and this acid fastness is again because of the characteristic mycolic acid present in its cell wall. The organism has a long replication time of 15 to 22 hours. Tuberculosis of skin can be classified in various ways. The three main bases of the classification are: one, mode of inoculation, second, immunological state of the patient, and third, history of previous sensitization with tuberculosis. So these are the questions which we should look for before classifying tuberculosis into primary or secondary. In primary tuberculosis, it is seen in patients who are TB naive. And the example is TB chancre, and this will be a multibacillary form of leprosy because the patient do not have a pre-existing immunity against the bacilli. The secondary tuberculosis is seen in individuals who have had previous sensitization with the organism, and this is much commoner form of disease in our country. The example include Lupus vulgaris, tuberculosis verrucosus, and scrofuloderma. Acute post-primary TB is usually seen in patients who are either immunocompromised or very sick. This is again a multibacillary form of leprosy. Example includes miliary tuberculosis and tuberculosis aurificalis. And the last one is tuberculosis hypersensitivity, also known as tuberculids. These are immunological phenomenon to or immunological reaction to circulating tubercular antigen. That means demonstration of a tubercular foci in these patients may be difficult, but they do respond to anti-tubercular therapy. And that's why are included in the same group. The example of tuberculids include like in scrofuloderma, papillonecrotic tuberculid, and erythema induratum. We will discuss secondary tuberculosis and tuberculids in detail because these are the common form which we encounter. The first of cutaneous tuberculosis is lupus vulgaris. This is the commonest form of tuberculosis in adults, and it is usually seen in the exposed site, again because of the mode of inoculation. Lupus vulgaris can either be acquired by external inoculation, but also it can be acquired by hematogenous or contagious spread. So all three modes of transmission are possible in this form of tuberculosis. It usually starts as erythematous infiltrated papillary lesion. The lesion then slowly progresses and increases in the size. But this characteristic evolution where progression is seen at one end and scarring and resolution is seen at another end is very distinctive and diagnostic of the disease. So this is called plaque type of lupus vulgaris. This is the commonest form. Rarely we see nodular, hypertrophic or keloidal, sometimes sporotrichoid form of lupus vulgaris as well. So this is an example where patient has developed tuberculosis at the site of BCG inoculation. This is an unusual variant, sometimes seen in children post BCG vaccination.
Tuberculosis of the skin, again, like tuberculoid leprosy, usually you see a dense inflammation, which is involving the upper dermis and variably going into the mid dermis and maybe even the lower dermis, tracking along the appendages. There is a follicle which is surrounded by this characteristic inflammation. And even on this very, very low power, you can make out that, there are these lymphocytic collections, the blue ones, and then there you have these pinkish aggregates, these guys. What are these? Granulomas. And classic granulomas of epithelioid cells, which are activated macrophages, Langerhans giant cells, necrosis. At times in skin tuberculosis, it may be difficult to make out necrosis. Many times, necrosis is not recognizable. And then you have a problem with all the other granulomatous disorders of the skin. When you have a reasonable amount of necrosis, of course, you think of TB and that's it. But when you do not have necrosis, then you have a problem. you start looking for even some necrosis. And some necrosis you will see. It may or may not be as marked as this. It may be, focal as it is seen here or here. And just one little thing about reticulin. Some of you from pathology would remember that reticulin is a stain which is used to distinguish sarcoidosis from other granulomatous disorders. Essentially, these granulomatous disorders, almost all of them, whether they are leprosy or tuberculosis or fungal or whatever, because there is so much inflammation going on, the reticulin is destroyed. The sarcoid is the as you can make out here, large areas of description of destruction. Sarcoid is the exception because of the peculiar immunological activities going on there. There may be an actual increase of reticulin, or you may be able to make out the normal reticulin. So, Dr. Neetu had mentioned scrofuloderma. Scrofuloderma is a lymph node, which is a tuberculous lymph node, which has burst through the overlying skin, usually seen in the axilla, neck, groin, and so on. Neetu?
Yes, sir. So scrofuloderma, as we discussed, is second type of secondary tuberculosis. It is the commonest type of tuberculosis seen in children, and it is seen in patients who have had an underlying foci of infection. So this foci may be present in a bone or in a joint or in a lymph node or in the testicles. And then it shows this contagious spread of infection to overlying skin and subcutaneous tissue, resulting in these bluish red papillonodular lesion, which will eventually break down to form ulcers communicating sinuses and fistulas, and then will heal with characteristic scarring and contractures.
So when you do a biopsy of a, sorry.
So this photo shows the characteristic ulcer. So ulcers of scrofuloderma, they are well defined. They are known to have this undermined edges and granulation tissue at the base. And the second photo is showing it's healing with scarring and contractures, which is again diagnostic. Like even if we see patient at this stage, we can determine that probably this patient have had scrofuloderma in the past.
So in a biopsy from scrofulodermatous lesion, you may, of course, depending on how deep you have gone, you may see that lymph node. You biopsy that lymph node and you will see it as a tuberculous lymph node. But when you have a tract going through from the lymph node to the outside atmosphere, it's usually not advisable to dig very deep into the lymph node, because the superficial biopsy itself at times may give you the diagnosis. And as mentioned here, if you go into the lymph node, of course, you'll have the classic features of a tuberculous lymph node, epithelioid cell granulomas, cases necrosis, and so on. In the skin biopsy, actually, there are 2 or 3 components which are playing. One is that the tuberculous infection is coming through from underneath. It has burst through the skin. So basically, there is tuberculosis of the soft tissue and of the skin. The other element which plays with this is outside infection. Unless and until very, very rigorous dressing and covering of the sinus is done, there will be infection from outside. That will be acute bacterial infection. So that may be interplaying here. There is another very interesting thing which the the pathologists and the dermatologists would find perhaps of interest. Usually, the way we talk about mycobacterium in Lepromatous leprosy, and maybe even in borderline, and maybe even in BT leprosy. In tuberculosis, mycobacterium is less recognizable. So in a tuberculous lymph node, if you do acid-fast stain, it would be very difficult to pick out one or two or three bacilli. But the other histological picture is supposed to be quite diagnostic. Now, when the lymph node is connecting to the outside air, something very dramatic happens. The Mycobacterium tuberculosis, as you know, it's an obligate aerobe. It thrives at 100 millimeters of oxygen. So when it is closed, whether it's in the lung or in the lymph node, the oxygen it is permitted to, it is exposed to is whatever the oxygen of the blood is. But when it is connected to the outside, the oxygen level goes up to 130, 140. And in those circumstances, the Mycobacterium tuberculosis may start proliferating. So in scrofuloderma, if you take a biopsy of the sinus tract, it may be more positive than usual in tuberculosis. Matter of interest, actually. Again, this necrosis, this necrotic material of the sinus, this itself may also contain many acid-fast bacilli. Neetu?
Yes, sir. And the third form of secondary tuberculosis, which we see commonly, is called tuberculosis verrucosa cutis. And as the name suggests, the lesions start as verrucous papule. Verrucous means something which has a rough, uneven surface. So you can see that the lesion will start with as a small verrucous papule surrounded by an inflammatory areola, and slowly it increases in the size. It is known to have this finger-like projection, and then it forms this verrucous large plaque, usually again seen more on trauma-prone side. In Asia, buttocks in children is a common site, while extremities are common sites in adults.
As reflected in the clinical picture, marked hyperkeratosis, marked acanthosis, and a dense inflammatory infiltrate underlying. Because TBC is usually a long-standing process, at times it may be difficult to make out the tuberculous process in this. So you may have these features of a huge hyper and parakeratosis, acanthosis, inflammation. But actually to find a granuloma in this may need a little hard work. Hard work meaning you may have to, take a largish biopsy, do multiple step sections, and then maybe in one of them you will come across the granuloma which supports the diagnosis.
And this is important clinically also, as sir mentioned, because the lichen planus hypertrophicus is the close differential diagnosis apart from chromoblastomycosis. So we have to look carefully. Sometimes step cuts are required, deeper sections are required, so that granuloma can be recognized and the correct diagnosis can be made.
Some of the fungal disorders also can
Chromoblastomycosis is a close mimicker of the condition.
You have to look carefully for, something to give you a hint to the diagnosis.
Right, yes, sir. So among the tuberculids, lichen scrofuloderma is the one commonly seen in children, and trunk, that means chest, abdomen, and back are the common site for their presentation. And the commonest presentation is these grouped, monomorphic, shiny, small, lichenoid papular lesion. Usually, again, we will look for tubercular foci, but not seen. Mantoux test is positive, and these patients, they respond well to anti-tubercular therapy.
And as the clinical itself may be very, confusing or misleading, so is the histopathology. Here, of course, is a fairly clear-cut case. You have this follicle which is being inflamed and surrounded by the inflammation. And you have here granulomas forming around this follicle. And of course, the reactive changes, hyper and parakeratosis. But at times, these tuberculoids, all of them, may be difficult to make out on the histopathology.
Second form of tuberculid is papillonecrotic tuberculid, also known as PNT, and this is seen in adolescent and young adult. Extremities are the common site of involvement, and patient present with these crops of erythematous small papular lesion on the extensors of extremities, and then they resolves in few days with characteristic varioliform scarring. Again, a tubercular foci is hard to find, and patient will respond well to anti-tubercular therapy.
You can make out here the granuloma and the necrosis. At times, there may be a considerable amount of necrosis, but this is one of the confusing areas of dermatopathology.
And third form of tuberculid is erythema induratum. It is seen in middle-aged women where calves, posterior aspect of lower leg are the commonest site of involvement. Patient present with these painful, very tender erythematous nodular lesion. They may be associated fever. They rupture to form these well-defined punched ulcers and may heal with scarring. Again, tubercular foci is looked for. It may be occasionally found, and patients are treated with anti-tubercular therapy whenever we can find a tubercular foci with it.
And as Neetu said just now, in this particular lesion, induratum, because there is a fairly extensive inflammation going into the underlying fat and causing a new spin to the histopathology. Because as you know, any dense inflammation of the subcutaneous paniculars can itself cause something like a fat granuloma, because the histiocytes, there is fat necrosis. Histiocytes will take up some of the degenerated fat, and you start mistaking them for epithelioid cells. So at times, this can be a confusing picture. So whenever you see a granuloma-like condition or foam-laden histiocytes in fat area, be careful. And of course, we've taken out the nice biopsy. So granulomas, necrosis, and the other issue which Neetu had mentioned, a moderate sized blood vessel, which is getting involved with this. Here it's at a little distance, but at places you actually have tuberculous vasculitis, which causes these dense, deep, punched out ulcers. Thank you.
Thank you, sir. And
we have
Bhari?
done an hour and 5 minutes. So do you want to go on to the questions, or do you want to go on to
I can leave it to you, whatever is convenient to you. If you want to complete
that
later
depends.
this,
If somebody wants to ask some questions or discuss something, then we can go on with that. We have also a small little thing on leishmaniasis prepared, but we could always do that in the future sometime. Combine it with one or two of the other infections, maybe fungal or viral or something. So
Right. Right.
depends on the questions we have.
We have a few questions, but not too many. So maybe if you think that you can complete leishmaniasis, you can as well go ahead.
Well, it's like this. It's sorry,
Yeah,
uh,
it's
or
one
so.
hour, 5 minutes.
Leishmaniasis will take us another 15 minutes or so. So, which means then we'll be reaching 11 o'clock.
So then let's take the questions then, and we can do the leishmaniasis at another time, sir, next week.
Sure, certainly.
So one question that has come from this one of our viewers is so this question is for Dr. Neetu, is how clinically do you differentiate between cutaneous tuberculosis versus tuberculoid form of leprosy?
Right. So that's a good question, sir. Tuberculoid form of leprosy versus cutaneous tuberculosis. I think the confusion may arise if you are talking about lupus vulgaris form of cutaneous tuberculosis, because as we saw, scrofuloderma has a distinct morphology, and so does tuberculous verrucosa cutis. In lupus vulgaris, the lesions start as infiltrated erythematous papillary lesion, and then it progresses slowly with a characteristic evolution. So the confusion may only arise if you see in the early stage of the disease, because in a well-formed lesion, you will see a characteristic scarring at one end and progression at another end. So which is very different from a tuberculoid leprosy lesion, where there is an erythematous or hypopigmented or hyperpigmented plaque with surface changes which are limited to cirrhosis or scaling. Usually we don't see pustulation or ulceration or crusting. So these secondary changes are mostly seen in cutaneous tuberculosis, are not present in tuberculoid form of leprosy. That is the one clue. When we see a lesion, we see the surface of the lesion apart from its color, if we have to differentiate it from early form of cutaneous tuberculosis. The second investigation or bedside test, as we can see, will be pinprick test to demonstrate the hypoesthesia in the lesion. So though in any granulomatous disorder, we may see some reduction in the sensory phenomena, we may see some sensory impairment, but in tuberculoid form of leprosy, the sensory impairment is marked. So if you compare it with the normal skin, 90 to 100% sensory loss will be there. You may see 20 to 30% in any granulomatous lesion. Then the third distinction will come from the nerve palpation. So we will look for feeder nerve involvement in tuberculoid leprosy and any adjacent nerve if it is involved, which may not be there in case of cutaneous tuberculosis. I hope this answers your question.
Yeah, definitely. Thank you, Dr. Bhari. There is another question for Dr. Singh, I think on the same line, that how do you differentiate histologically between cutaneous tuberculosis versus tuberculoid form of leprosy? Because in many other countries, this may be because they don't see much. So this might be a very relevant thing to know.
Um, First of all, I'd like to um, emphasize what we have been talking about for many years now, about viewing the clinical features and the histological features and other features in their entirety. So, if you have a clinical indication and then you are looking at the histology, you are, already far advanced on the road to a diagnosis. If you have, say, a no history slide showing a granulomatous inflammation in the skin, you may, at times not be able to distinguish the two at all. But however, there are certain clues and pointers. One is the most important one, of course, is the nerve involvement. M. leprae is a preferentially neurotropic bacillus. So it will involve the nerve. And what we did not go into the detail earlier, when you do an acid-fast stain in a tuberculoid leprosy, and most of the granuloma and the necrosis and all is negative. But where do you expect that it may be positive? In the nerve. So, in fact, if you do AFB in a granulomatous inflammation and look at the nerve may or may not be showing destruction. The nerve may or may not be showing acid-fast bacilli. So if you see either of these, then you know that you are in the leprosy zone. The other thing is necrosis. Tuberculosis usually has more necrosis. Tuberculoid leprosy does have necrosis, but it is much less prominent than it is in tuberculosis. So that is a lesser sort of indicator. Nerve involvement, yes. And of course, if you have a good clinical description, then much of your diagnosis is made in any case.
Right. Thank you, Dr. Singh. So there is a question for Dr. Bhari, I can see. So the question is it clinically relevant to classify the different forms of tuberculosis, and are there any different treatment modalities that is different for the different types of cutaneous tuberculosis?
Right. To classify in different type of cutaneous tuberculosis is important, because as we saw that some form of tuberculosis are more commonly associated with your systemic form of tuberculosis, that is involvement of lung, any abdomen, GI involvement. So if we see those form of cutaneous tuberculosis, we have to evaluate it more vigorously. And in that case, the duration of treatment increases. So if you have systemic tuberculosis, the duration of treatment increases. So that is one reason why we should be able to clinically differentiate into different type of tuberculosis.
There is another question on the same line. I could see that. What is the classical medication that you give for cutaneous tuberculosis, and what's the duration and how many combination of drugs that you give?
Right. So we have guidelines from WHO, extrapulmonary tuberculosis guideline known as index guideline. There are 4 main drugs which are the first degree treatment, though in resistant cases there are other drugs as well for cutaneous tuberculosis. The drugs regime we have is usually we have an intensive phase, then we have a continuous phase. In intensive phase, we give isoniazid and rifampicin. Nowadays, ethambutol is also added, and then pyrazinamide is the 4th drug. So 4 drugs are given in the intensive phase, and then we have so intensive phase is for 2 months, and then we have a continuous phase, and there we use 2 or 3 drugs based on different guidelines, and those drugs will be isoniazid, pyrazinamide, and ethambutol. Sometimes injectable drug like streptomycin is added, particularly in systemic form of tuberculosis. And if we find a resistant bacilli, then second line drugs like ofloxacin, ciprofloxacin, like levofloxacin, that group of drugs are also added.
Thank you. So this question is for Dr. Singh. The question is about molecular testing. Is that, do you do PCR for definitive diagnosis?
PCR for us, it's now gaining more and more importance, but usually no, because the diagnosis of tuberculosis usually is fairly well as tuberculosis of the skin is fairly well established at using the clinical description, morphology, and so on. PCR is usually of more use in internal tuberculosis, where you don't know what is actually causing the symptomatology. Because the skin is right out there, you can biopsy it. If you have a lesion which you may pick up on radiology in the lung or in the liver or in the intestine, uh, the only way of accessing it, the easiest way of accessing it may be an ultrasound guided FNAC. So, unlike the skin, where the biopsy is eminently possible and easy, and more than one biopsy can be done. So usually PCR has been done. It has improved the positivity of tuberculosis in some series, but it's not a usual test which we do for skin tuberculosis.
Right. Uh, there is another question for you, Dr. Singh. The question is, can Mycobacterium avium complex infection in immunocompromised patients look similar to leprosy histologically? And how do you help to differentiate?
Absolutely, absolutely. Um, 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 these the other mycobacteria can both clinically and morphologically be great misleaders, because skin involvement also, exclusively skin involvement, may be seen. You may have multi-system involvement, and then because the chemotherapy may depend on it, the only way of trying to identify these or distinguish these is various microbiological tests, culture, PCR, and so on and so forth, because the treatment regime may be different. Many of them may not respond to the classic tuberculosis or leprosy treatment. So at times it goes beyond our hands into um, ways of distinguishing in the microbiology department.
Right. Thank you. There is a question for Dr. Bhari. The question is about sarcoidosis and cutaneous tuberculosis. That how do you clinically differentiate between these two entities?
Right. And before that, I just want to add regarding the last question of Mycobacterium avium complex, which is an atypical mycobacteria. So clinically also they present quite differently from leprosy. They are more in proximity to tuberculosis because scrofuloderma-like presentation can be seen. So they mostly present with nodulo ulcerative lesion rather than a plaque form of the lesion. So they are more in as a differential diagnosis of tuberculosis rather than leprosy clinically as well. And then, as sir mentioned, distinguishing it from tuberculosis and leprosy is important because treatment is different. So sarcoidosis, I think it is easier to differentiate clinically from tuberculosis because one, the number of lesions, sarcoidosis usually present with multiple lesions. They may be single lesion in certain type, but those are the types which has characteristic morphology. So they are easy to distinguish. The commonest type of sarcoidosis is plaque sarcoidosis, which is usually seen on the trunk, that is on the chest, shoulder area, upper back, in the form of multiple erythematous plaque lesion, and these lesions, they have minimal surface changes. So this is how they present. And then in comparison to tuberculosis, as we saw, the lesions are fewer in number, they have much more surface changes, ulceration, scarring, etc. are much more prominent. So clinically, at least to plaque sarcoidosis, it is easier to distinguish it from cutaneous tuberculosis.
And this question is also for Dr. Singh. To add to that, I think probably you have answered, but still, that how do you histologically differentiate between sarcoidosis and tuberculosis?
With great difficulty. With great difficulty. And in fact, let me tell you, in the skin, we are actually better off than the internal medicine people, because you have a patient coming with fever, you've got some lesions in the lung, and they pose the question of sarcoid versus tuberculosis. And they are stuck with great difficulty. They do a biopsy, lung biopsy or whatever it is, and then we get stuck. Because, sarcoid, of course, does not have Mycobacterium tuberculosis. But that's fine, because many cases of tuberculosis also don't have Mycobacterium tuberculosis. There are other biochemical tests and so on and so forth, which at times may help. Because skin, usually there isn't a problem. So, because the morphology, as we had seen, is fairly characteristic. Sarcoid, you will not have necrosis. TB, you will have necrosis. In sarcoid, actually, you have a condition known as necrobiosis, which is a small amount of necrosis present in the center of the granulomas. Some people find it difficult to distinguish necrobiosis from actual necrosis. The reticulin test can be of great help, because in tuberculosis, like all other inflammatory granulomas, infective granulomas, there is inflammation and there is restriction. So the reticulin is reduced. In sarcoidosis, what people say, of course, is that reticulin is present, but actually it may even be increased in amount. We have some very pretty photographs of increased amount of reticulin compared with the outside material. But it can be a difficult decision.
So do you suggest to the pathologists where they're not very conversant in dealing with tuberculosis versus sarcoidosis that they can use the reticulin stain to distinguish between the two?
We do. Reticulin stain has the sanctity of age, because when other ways of distinguishing were not available, then one used reticulin, and at times it helps. But TB versus sarcoid is such a situation where almost nobody is going to be 100% correct. There will always be an element of doubt, compounded by the fact, of course, that to give steroid or not to give steroid. Because one may be helped by steroid, the other one may be exaggerated by steroid. So it's a difficult situation.
So there is one question for Dr. Bhari, I think. Are you there? So the question is about immunocompromised patients. Like, I mean, in the wake of HIV infection, and how often do you see, tuberculosis or leprosy in such patients, and what is your experience in India?
Right. So in the current era, when HIV patients are commonly seen in our department, and both leprosy and tuberculosis co-infection is seen. Tuberculosis, we have seen few patients where just based on the morphology, we are able to at least suspect that this patient may be immunocompromised and we should evaluate. So that means tuberculosis may be the first presentation of the patient. HIV status may have been unnoticed till then, but the vice versa is also true. In a known HIV patient, presenting with tuberculosis is also possible. As we saw that miliary tuberculosis is a form of tuberculosis seen in immunocompromised patient. Similarly, multiple TB gammas are seen. So in scrofuloderma, we see a single lesion. But if a patient present with single or few lesion, but if a patient present with multiple gummatous ulcerated lesion, we may suspect that patient have some immunocompromised state, and we may suspect or evaluate him for HIV positivity. And in both these states, because we know that if there is a co-infection with HIV, treatment resistance is a problem. So that's why this distinguishing or this evaluation is also important, that if there is a co-infection with HIV, a close watch should be kept to see the treatment response. And if treatment response is low, we should evaluate for resistance in both the cases, HIV tuberculosis and HIV leprosy.
Right. I think there is this question also you can take, Dr. Bhari, is about extracutaneous forms of leprosy. So maybe that question can also go to Dr. Singh, that what is your experience about, have you seen any extracutaneous forms of leprosy elsewhere?
So extracutaneous form of leprosy, we usually see in patients with type 2 reaction, where there may be involvement of nerve for sure, there may be other organ involvement as we discussed, involvement of liver, kidney, endocrine system may be involved, hematological, suprarenal. So we have to evaluate if patient has presented with this. Pure neuritic form of leprosy, again, it is an extracutaneous form where only nerves are involved. As sir mentioned, in that case, that nerve abscess may be the presenting manifestation. And sometimes we don't see the cutaneous lesion. We see is a patient presenting with motor impairment, patient presenting with wrist drop, foot drop, claw hand, trophic ulcers. So then again, we have to suspect and evaluate a patient for leprosy. So this may be a presenting manifestation as well, and we have to evaluate and treat for leprosy. Sir,
So,
anything to add, sir?
yeah, no, so my question in that sense, I presume that this is, what is it called? Lepromatous form of leprosy. Is that correct?
Yes. So this has to be a florid or an advanced form of leprosy, multibacillary form of leprosy.
May I point out here also that M. lepri, the growth optimally is lower than the normal human temperature. Optimal growth is some 32, 33 degrees or something. So there is a preference for the cooler part of the body, which is of course the skin. And even though of course it does occur everywhere else, but preferentially it occurs in the skin because there is a preference for the cooler parts of the body.
Right. I think with that, we have almost come to the end of the session. So there is a comment I think Dr. Bhari and Dr. Singh would be happy to hear that. Let me read it for you. So this is from one of our viewers who is Dr. Sujata Baliza. So she mentioned that she did her MD thesis on Ridley-Joplin classification of leprosy in 1991 at Tirupati AP Health University. And she has a great passion for the topic, and she also comments that that fight Farrago stain that she used and they still use it. So she's great happy to hear that. So I think thanks to Dr. Baliza for your nice comment, and thanks for attending this talk and listening to Dr. Bhari and Dr. Singh about this classification of leprosy and also cutaneous tuberculosis. So thank you again, Dr. Singh and Dr. Bhari, for this great presentation on leprosy and cutaneous tuberculosis, because these two diseases are, of course, very prevalent in some parts of the world, like in India, and in many places, especially residents and community pathologists, they might not be seeing these two entities very commonly, and I hope that it would be a very useful for them, and especially for the trainees, that when you see tuberculosis or granulomas on the skin, you should also think of tuberculoid forms of leprosy sometimes, and maybe not always it is tuberculosis or sarcoidosis. And you both would be happy to hear that our live lecture was attended by several hundred viewers from across the world, and I could keep a track of some of the countries that were represented. I could see viewers who joined from Peru, Serbia, Iraq, Nepal, Romania, Bosnia, Mexico, Guatemala, Algeria, Ireland, India as well. And thanks to our viewers for defying the time zone and listening to our talk. And if you like our lecture, don't forget to follow our YouTube channel, that is Pathcast, and you can also follow our Facebook page. And if you go to our website, that is pathologycast.com, so you can see the lectures arranged uh, by subspecialty. And our next lecture is coming up soon, so that will be on April 18th, and we will switch to ophthalmic pathology. So Dr. Franz Vogt, who is chair of pathology at Pennsylvania Hospital in Philadelphia, he is going to give a talk on ophthalmic pathology on April 18th. And we will have subsequent talks on infections of the skin by Dr. Singh and Dr. Bhari, and they are going to cover other infections of the skin like leishmaniasis of the skin and viral and fungal infection as well. And we will keep everybody posted. And thank you again, both of you, for your time. And that's an excellent talk. Thank you.
Most welcome.
Sure. Can we leave